Welcome to Category Visionaries, the show dedicated to exploring exciting visions for the future from the founders who are on the front lines building it. In each episode, we'll speak with a visionary founder who's building a new category or reimagining an existing one. We'll learn about the problem they solve, how their technology works, and unpack their vision for the future. I'm your host, Brett Stapper, CEO of Frontlines Media. Now let's dive right into today's episode. Hey everyone, and welcome back to Category Visionaries. Today we're speaking with Amar Kendale, co-founder and president of Homeward, a healthcare technology company that's raised over $70 million in funding. Amar, how are you?
I'm doing really well. It's great to be here with you, Brett.
Amazing. Super excited to have you. So on your LinkedIn, I see that you've spent the last 2 decades building products and technology that shape the future of health and improve lives. So I want to start there. Where did that mission statement come from for you?
Sure. So our experience at Homeward at its inception, for myself and my business partner and co-founder, Dr. Jenny Schneider, really arose in our prior experience together with a company called Livongo Health. And at Livongo, we were delivering services for people with chronic conditions, things like diabetes and hypertension. And our service was offered nationwide, typically through employers. So we're reaching a very broad swath of people. But one thing we observed that was very interesting was that we were having an outsized impact on rural employees. So folks who are in rural Maine, for example, or really, frankly, you name it, every state in the US has a rural area. And so for those individuals, what we're hearing back from them was that this was a lifeline. The ability to use technology to connect them to care resources is something that they'd never experienced before. And because of the logistical challenges of living far away from care, this was really making a difference. So, that seed was planted back in those days. And when Jenny and I were starting to scope out, where we wanted to spend the next decade plus of our lives, we were looking for a few things. We were looking for a place we could have real meaningful impact, a place where there were health disparities or outcomes that just needed to be better than they were. We were looking for places where we could align the business model with the needs of the population. So that brought us to value-based care as the concept we wanted to be embracing as the basis for what we were doing. And third, places where technology was not just a nice to have, but really critical in order for any kind of solution to work. And we found all of that in rural America. We found these massive health disparities. We're talking about 23% higher mortality for rural Americans relative to their urban and suburban counterparts. When you start to peel back the onion and look to figure out why, part of it's explained by the fact that you have only half as many doctors, primary care doctors. You have an eighth as many specialists. You have 700 hospitals that are due to close, that are at the risk of closing. And so the nature of the problem here and why we're seeing what we're seeing, you can start to get a handle on, okay, there's a real resource shortage. And then that brings us to this aspect of technology, which is if this resource shortage is there, we're not going to fill this by trying to persuade more doctors to move to rural areas. There's no way, to solve the solution in a brute force kind of way. So technology is going to be an essential part of what we need to bring to rural America in order to turn things around.
So you decided to pursue this problem and build a solution here. What other opportunities were you considering that you ended up not going with?
Yeah. Well, the good news, I guess, in healthcare is there's no shortage of problems and no shortage of big problems. We were also very passionate, I think, about opportunities to see how specialty care can really extend its reach. And, it's a bit of an artifact that we have specialists attached to hospitals or health systems. The majority of the work they do is non-procedural. 60% of the work is non-procedural. So there's a lot of reasons for why that's become ossified in the healthcare system, billing being one of them, and the way that hospitals generate revenue with the way they collect proceeds. But when it comes down to the nature of the work, the ideal is a world where we could untether our specialists from a physical site and make their capacity available more broadly. So our thought was, is this the moment when specialty care can start to get virtualized and distributed more freely across the areas of need? Similarly, we were interested in doing this in a value-based care kind of construct. And we have some great examples in kidney care where this is beginning to happen. We're not moving quite as fast in other clinical areas. And so that's something I think that we continue to watch and are still very excited to see. And, I think at Homeward have a chance to participate in somewhat as well. We're very interested in the way that value-based care is showing up in pharmaceuticals. The punchline is really not. By and large, there isn't much in the way of outcomes-based pricing when it comes to pharmaceuticals. And so that was an area we were very interested in exploring because it ought to be the case, that high-cost medications are really attached to delivering better outcomes for patients as opposed to other, artifacts that are driving the way they're priced. So another area I think of a lot of interest, the amount of spend that goes into pharmaceuticals is rising. And so it is an area of opportunity. And particularly in a world where we could align incentives, that's something exciting to us. And then, we have these other more general trends that we find to be really fascinating around value-based care and the way it works. In today's market, most of that value-based care work has been centered on primary care. But, what about a world where every participant in the value chain for delivering healthcare services could sign up for delivering outcomes? What if there were a way for us to sort of distribute the load so it doesn't all sit on primary care, but instead we had mechanisms to propagate, that delegation of risk across the entire ecosystem? It would start to create some really interesting phenomena and eliminate a lot of the distortion that we have in healthcare. This is one of the most, perversely distorted markets that exists in America for a lot of reasons. But if we could start to straighten out some of that, with more clear incentives, we think that there's some profound impact to be had. Another thing that I think at Homeward, we see our opportunity, as we're building this business and service, for rural Americans, at least, we see an opportunity to deliver some of these capabilities to that group.
When we look at value-based care, I'm not in the healthcare industry. Whenever I hear people talk about it, I think, yeah, great. That sounds awesome. It seems like a no-brainer, but I understand it's more complicated than that. If there's critics out there, which I'm sure there are, of value-based care, what is their criticism of it? What do they say? It just doesn't work? It can't work? What are those critics saying?
It's a great question. So value-based care, I think, has really been growing in its presence, certainly accelerated over the last 10 years, since the Affordable Care Act. That's really when things started to gather momentum. And, initially, I'd say there was, just critics more generally of that entire set of policies. There was obviously a lot of divide around how we go about changing the way that care is delivered and paid for. I think in more recent years, now that we've seen a couple of full cycles of value-based care in the market, we've seen what's working well and what's working isn't. I'd say the most kind of articulate critics have shaped an argument focused on all of the ways that the incentives can be perverted and, used to ill effect. So one example is a concept called risk adjustment. And the way this works is a population has some amount of disease burden, people are sick. And it used to be the case that providers get paid for those sick people, whether they're, the amount of influence of their complexity on how much provider gets paid is pretty limited. Mm-hmm. And it's more tied to how much time, that's the kind of dominant factor, is how much time the provider's spending. So utilization-based model of reimbursement. In value-based care, the idea is that the reimbursement should be based on the complexity of the patient. So suddenly it created a lot of motivation to go find complexity. And so, as with any incentivized behavior, now you have, lots of people looking to see, is this, maybe there's more disease here and I should be looking for it. In some cases, it's led to abuse of that system and folks, documenting disease that isn't even there. Or probably more typically, documenting disease, but then not really doing anything about it. And so I think those are some rightful critiques of the way that, value-based care has been working to date. I think, we're seeing some appropriate tightening up of the regulations around this, particularly in terms of how, disease burden should be captured and coded and reported. So there's some, as with anything, there's improvements that only can really show up once you had a full cycle of experience. I think the other piece of this is, how do you keep that sort of transactional mentality out of value-based care where someone's just focused on that front end and capturing all the codes and then walking away? I'd say that's been very central to our approach at Homeward, is to say that's not real value-based care. That's not real responsibility and long-term partnership with our patients and with their providers and with the payers. That's only going to come from not only understanding what the burden of illness is, but doing something about it and making sure that something happens that's going to, bend the arc of the outcomes. In a lot of cases, it means, for example, you find a person maybe hasn't been diagnosed with high cholesterol or high blood pressure. The onus, should be on all of us in value-based care when we identify those things to immediately act to help to get that patient under, good medical management and ideally those conditions under control. So that follow through really has to be there. And I'd say that's something that, we're very focused on at Homeward. And I believe that, we as a healthcare ecosystem can construct those incentives to work like that. It's not the default. And I think that's where it takes some longer term commitment in order, to really see those things happen.
This show is brought to you by Frontlines Media, a podcast production studio that helps B2B founders launch, manage, and grow their own podcast. Now, if you're a founder, you may be thinking, I don't have time to host a podcast. I've got a company to build. Well, that's exactly what we built our service to do. You show up and host, and we handle literally everything else. To set up a call to discuss launching your own podcast, visit frontlines.io/podcast. Now, back to today's episode. So you have this idea, you say, I'm going to spend the next, decade plus, solving this problem, building this company. What happened from there? What did the first, let's say, maybe 3 to 6 months look like?
Oh, well, we went on to rapidly make a series of mistakes.
First time
You
that's ever happened, right?
right?
No founder can say that.
Yeah, if you're doing your job, you're learning as fast as you can. And so, I'll share one anecdote about this, because our intent there was to make, kind of our mistakes quickly and when they were of the least consequence in a world where we could rapidly iterate and find our footing. One of the things I think we did right was we got into market quickly and we started seeing patients quickly and offering services quickly. And we felt very comfortable with this because this is a world where capacity is so short. It's, I think, less straightforward when you're entering a crowded market, right? To say, hey, we're going to be another doctor in a crowded market. Instead, we're going to this place where there aren't enough doctors. So we felt it was a balanced risk to say, we're going to go in and just start seeing patients and delivering care. And we're going to do it, in the interest of the patient, try to really elevate outcomes. So our initial take, as we looked at the data, what we saw was kind of bearing out what I shared with you earlier, Brett, which is there's about half as many primary care doctors. The way that was showing up for our patient panel was that about a third of people hadn't seen a doctor in over 2 years. Now, an interpretation of this would be to say, okay, well, those are people who probably need a doctor. So let's come out, we'll hang up our shingle, Homeward is here, come, we'll be your doctor. We'll be your primary care doctor. We can come see you in your home. You can see us in our mobile clinic. You can see us in one of our pop-up clinics. So we went out with that message and we struggled, candidly. We struggled to bring patients on. And as we found, there were some patients who tried our service and loved it and became kind of loyal and ardent supporters. They were getting exactly what they're hoping for was, lots of time with their clinicians and really great considerate care. But others said, I'm just not interested. And we asked them why. And they said, well, I have a doctor. And then we said, wait a second, though, you haven't seen anyone in years. So they said, yeah, I'm not dying. I'm not bleeding. I don't have any broken bones, so, I'm an independent person. And if I really am in trouble, that's when I'll see my doctor. And we said, oh, well, that's interesting. That means what's different about the way people are consuming healthcare in rural is the thing we have to pay attention to. It's not simply that there's not enough doctors, but it's what are those doctors spending time on and how are those patients interacting with their doctors? And so what we found was it's actually more nuanced. And it turns out that patients are getting from their doctors acute care. So when they're in trouble, they go to their doctor, they get the care they need in that moment for something that's a big problem. What it means for those doctors is that their days are full with very sick people. And so what's not happening is all the things that ought to be happening kind of in between those really complex events, those really sort of bad circumstances. And that's things like making sure you're getting your colonoscopy and getting your blood pressure checked and, managing your diabetes, right? Those are all things that are kind of longer term. They're necessary, but they're not acute. They're not like bothersome on a daily basis for most patients. And by the way, most doctors don't have the staff and resources to be doing the outbound, calling patients to say, hey, it's time for this or that or the other thing. And they don't have time in their day to see patients who don't have these acute issues. They're already working, long hours to care for their panels. So, that shape of the problem was different than what we initially thought. And so, within a few months, your point, 3 to 6 months, we really got our arms around this and recognized that our role to play was something different. It wasn't to be the primary care doctor, the only primary care doctor a person had, but it was instead to figure out what are the primary care services that are missing in the market because of the shortage of capacity.
You mentioned there getting to market quickly. That's not something I hear very commonly when I'm interviewing healthcare technology founders. What was the key to getting to market quickly?
Well, it was, I think, by deliberately deciding that we weren't going to start by building technology. I think there's a trap, a lot of technologists fall into, and I've fallen into it many times in my career, which is that you have a vision for the way that technology can play a role and start building first before you really know whether it's exactly the right problem or not. And then you build something and you take it to market, and now you're a little bit in love with your idea. And so when the negative signal starts to come in, you might resist it. You might reject it early on. We took the opposite approach. We said, we're going to build as little technology as we need just to get started. And then we're going to be very responsive. So we built our tech team on day one, and they were ready, and they were there learning alongside our clinicians. They were embedded in like the workflows and understanding kind of what was happening in a visit. They were sanding off some of the rough edges in the experience and making sure that things went smoothly in the course of a typical, onboarding and so forth. But we weren't building like heavyweight technology at that time. And it wasn't until really our second year that we felt a lot of conviction that we had the service oriented right, that we knew what kinds of outcomes and metrics we were going to aim at. And we really could build with conviction. And so when we started doing that, we were able to ship a lot of those services. And, the places in a business like ours where there's a lot of clinical operations, most of what you want to do is figure out places where you can streamline workflows. And so that's something I think there's just no way around running the workflows yourself. No matter how much you, kind of whiteboard it or strategize, you're going to be wrong. I'm going to misquote something here, but I kind of live by it. No strategy survives contact with the battlefield. I think that's absolutely the case, in a world like this, where it's highly complex, highly operationally oriented type of business. It took some forbearance on our part to not jump in and start building things because, Jenny and I have no shortage of ideas that we're excited about in terms of tech we could build, but I think it was the right call. And I think it's really served us well to continue to take that approach, even as we're making strides and growing the population and growing the services we offer, we try to launch it first in sort of more manual and operational way and use that as a basis to decide where the technology investment is going to make the biggest impact.
Have you always had that product philosophy, or in other times in your career, did you have trouble where you overbuilt the technology that it ended up people didn't want?
Yeah, I'd say like the first half of my career is like a litany of, technologies I fell in love with that were a struggle to bring to market, and often this is the case with technology push, where there's a technology, it's a hammer looking for a nail. And so, there were cases in my prior life where, perhaps there was an enabling capability. I was working for a period of time on stretchable electronics. And, what an incredible idea, right? Electronics that have the same kind of properties as human tissue and human skin. And like, there's unlimited possibilities. That's the problem. There's unlimited possibilities. And so knowing which one to go after and to really go deep on, becomes the heart of the challenge, even when the technology is incredibly capable, it has enormous potential. And so, so that the risk there is you start to boil the ocean and you never do get to the one killer app or the thing that really would have made the difference. You may never get to it if you start with a very broad technology approach. We're watching a little bit of this right now with generative AI, where, these large language models, extremely powerful technology. And, we're watching a kind of generation of companies getting started saying we're going to be the Gen AI company for healthcare. And, I'm hopeful that they land on use cases quickly, because that's really what it comes down to is, they're sort of racing the clock between what the technology's capabilities are and what the market needs today. And the market's not going to wait. It might be the case that a lower tech solution can come along and actually solve the problem. I think it's one of the unique benefits here at Homeward in that we have both the care delivery arm of what we do, the people, the front lines, we're on the front lines delivering care ourselves, and we have the technology team that's using generative AI and getting deep into like the strengths and weaknesses of this set of technologies, what's it really good for and what's it not so good for. And so we're able to decide, where and how to apply it kind of within our own four walls, as opposed to relying on vendors and hoping they get it right for us, or, kind of throwing it over the fence to other providers and hoping that they know how to use it. So we kind of, in a sense, are sitting across both of those ourselves.
So I think that helps us understand the approach to product and technology. What about the approach to marketing? How would you summarize your approach to marketing healthcare technology?
So I think that healthcare is ultimately an industry that rests on trust. And historically, it's been a very local industry. Historically, people have consumed their healthcare locally. The brands that they've historically trusted are their local health system, hospital, maybe their primary care doctor, or family practice. And it's only recently that we are seeing the emergence of brands, certainly at the national level, that are trying to engender trust to varying degrees of success. And, in the challenged or negative column, you have health plans, which generally speaking, a negative net promoter score, very low levels of trust. You have health systems that are working at a larger scale these days as they're getting consolidated and aggregating. And so as they become more and more national, you see, higher net promoter scores, but lower than they used to be, as is natural, right, with that kind of phenomenon. And I think for Homeward, we're really trying to take advantage of these phenomena and kind of observe which lessons are the ones that we should apply in what we do. When we're building services at Livongo focused on chronic conditions, we enjoyed a very high net promoter score because we were solving very specific problems on behalf of our members, and we were interacting with them on a very personal level. So, our team of, at that time, it was certified diabetes educators. It was, our Livongo front desk staff, and it was our devices that we were putting in people's hands that created that opportunity to create trust. At Homeward, it's a little bit different. But the part that's the same is we rely on our frontline staff a great deal for building trust. And those are folks we hire locally. So in the rural counties that we're serving, we build our team on the ground that is directly interfacing with patients. Now, it's not the doctors, typically that we're talking about. We're talking oftentimes about our team of medical assistants, our community health workers. They're our front line. And they come from these communities. So they understand them really well. They have a really high degree of cultural competency. They are ambassadors, for the Homeward brand, which is a new brand, and one we have to introduce and, gently kind of educate people on, and here's who we are and here's why we're here and here's what we aim to do. But we have those ambassadors, who can help us to spread that message. And then the other part of building trust is delivering on what we promise. And that, I think, is a lot of what technology can do in a pretty unique way, where with traditional operations, you can have a lot of variability. Maybe, you end up with a long wait time on the phone. That's one of the most notorious, things that shows up. And how long, can we make you wait on the phone to get your, healthcare prior authorization or whatever it might be that you need from your health plan? Answer is people wait hours for that. And it's a terrible experience. It's a place that erodes trust. So that's a great opportunity for us to use automation and use technology to make a lot of those hassles go away. And if we can do that, then we can really start to create trust around the brand. The experience of Homeward is one where you can expect us to be responsive and efficient and value your time and be consistent. It shows up the same way every time you use us. So that's the complementary part to the things that we do, in the market on the ground. I think what it's meant for us is I think we're really finding our way to establishing our own presence. Homeward, here's who Homeward is, here's what we do, and here's how we show up. And then the last thing I'll say is a lot of our go-to-market comes from partnership. And it's sort of in any given market, we're partnering with at least two entities around a given patient. We're partnering with their health plan. That's who, we enter with, and that's kind of who, we're directly allied with. And we make every effort to partner with their provider. And so we've been very successful now in our first markets at creating structural relationships with the top health systems. And it's been a phenomenally rewarding experience for us to go do this. I think it really is a byproduct of learning, in some ways learning the hard way, that our role in the market is to supplement the existing provider, not to displace them and not to create abrasion or confusion for the patient. And so as we've gone about doing this, we've been able to build those bridges with providers and actually arrive at a place where they're eager to work with us. They actually look at us as a supporting, kind of element in their ecosystem. And so now here's Homeward, and we can say things like, we work with your doctor, because we do. We have a relationship with your existing doctor, and we coordinate care with them, and we help them do their job better, and we work with your payer. And so those are the ways that we've been able to situate ourselves and introduce ourselves and grow, frankly, very quickly, in a market that's traditionally not accustomed, to accepting new entrants and, kind of growing at the pace that we're growing.
This show is brought to you by the Global Talent Co., a marketing leader's best friend in these times of budget cuts and efficient growth. We help marketing leaders find, hire, vet, and manage amazing marketing talent for 50 to 70% less than their US and European counterparts. To book a free consultation, visit globaltalent.co.
That's a perfect segue to ask about growth. Are there any metrics or numbers that you can share just to tease us and tease the audience?
Sure. So I'll maybe start with what we always start with, which is, do our members love us? And so, our headline is a score of 80 on our NPS, which is frankly, better than we ever did, at Livongo or any other place we've been. This is true for Jenny and me. So it's an extraordinary score. I think it reflects both, the way that our care teams and our tech teams have built and delivered what they deliver. It also speaks to the need, and I think the depth of need that exists in our market and how grateful patients are, when we're able to offer them the kinds of services that we do. So I think it's some of both that contributes to that promoter score. I think the other metrics that, really matter to us are, do we have the reach and impact that we're hoping to? Are we actually, caring for as many people? So that's been a very rapid curve. And, I won't give specific numbers in terms of the number of members we have, but I will say that, compared to our predecessors, other value-based care companies, I think we're growing at a rate that's probably double the rate that they grew at a similar age. And so, in part, that's standing on their shoulders. They've done a lot of the hard work for us. And I look at the Oak Streets and the Village MDs and the Agilons as, companies we hold in extremely high regard and have learned a great deal from. Because of those things, I think we've been able to enter the market and grow, at a more rapid pace, still very cautious and, it's responsible growth. This is not the zero interest, days anymore. So, we grow very deliberately, but the demand is there in our market. And, rural America, I think, while it's been kind of a poster child, as a bipartisan issue, for a long time, I think we're reaching a moment now in the market where health plans really appreciate why it's important to strengthen their rural provider networks, and providers are open to help in a way that's new. And so the demand is there. And I think that also is reflected in our rate of growth. So we're, roughly tripling to quadrupling the business every year. And we are on a very strong trajectory there with, ample demand looking forward. And then finally, I think, the next thing that matters is, once we have the scale pieces sort of figured out, are we delivering on our promise of clinical quality and outcomes? And that's where we're also seeing, really strong early data. And, one of the places we focus on, for example, is gaps in care. So this reflects, where are there things that are clinically known to be necessary, for our patients? And what are they actually getting? And can we bridge that gap? So we focus a lot of our effort on understanding how big those gaps are and then pointing our teams at helping to close those gaps. And that's another place where we're seeing really strong early results now. And I think is another part of the foundation that we're building on.
As you reflect on this journey, what do you think's been the most important go-to-market decision you've made? And take us behind the scenes. How did you make that decision?
Oh, wow. That's a good one. And this is another one where, if you ask me this question in 5 years, Brad, I think I'll have some really wonderful kind of revisionist history to say how this is all, so carefully plotted from day one. I think, to be honest, the strategic decision is probably the one I alluded to earlier, which is coming in with a lot of humility and knowing that we don't know the answers and knowing that we're going to learn very fast and be wrong a lot. I think doing that before the stakes are so high that they could kill the business, is probably the most important thing we did, as we're growing Homeward. I think that, we were fortunate in our selection of markets. And I think that's an example where we had some strategic intuition and then subsequent work really kind of ratified that for us. So for example, the two markets we entered early on were Michigan and Minnesota. And we came in with a focus on Medicare and specifically Medicare Advantage as the population that we would serve to begin. As I mentioned at the very beginning, there's rural communities all across America. Every one of the 50 states has rural communities in them. But Michigan and Minnesota have a large proportion of Medicare beneficiaries and a large absolute number of Medicare beneficiaries. So as far as markets to go into, because there are a lot of factors in starting up a new practice or care delivery arm that are kind of happen at the state level. And so, you could easily die by 1,000 cuts if you go after too small a market. You pick, Delaware to start, right? Probably not enough headroom given the cost of standing up the market. But we chose markets that really have given us a lot of headroom. And it's both because the Medicare populations are large, the Medicare rural populations are large, and because the partners that we've chosen to work with, share our vision for what rural healthcare can be. And so I think those are areas where, we had a strategic hunch. And then our time in the market really proved to us that we've made some good decisions. And now that's become a template for us and part of our playbook. I think we know what attributes we're looking for now as we consider the markets that we'll be adding as we grow.
What about lessons learned from fundraising? So as I mentioned there in the intro, over 70 million raised to date. What have you learned about fundraising this time around?
So, the kind of business we're in is very capital intensive. This is not a place where you can run, lean startup or, I think some of those sort of SaaS oriented financing techniques, factoring or customer-led financing, those sorts of things are challenging in an area like this in healthcare where we're doing care delivery, we are a provider in the way we operate, we're doing value-based care, and we're a technology company, all those things. So I think our most important decision at the very outset was choosing our investor partner. And that was actually a pretty easy decision for us. It was General Catalyst, and specifically Hemant Taneja at General Catalyst. Hemant's someone that I've known, for well over 2 decades. But Jenny's also gotten to know very well during our time at Livongo, where Hemant was the earliest investor, the earliest kind of institutional investor at Livongo, really a co-founding investor there. And so we really wanted Hemant to be our co-founding investor at Homeward. And in part because he thinks as big as we do and pushes us, in fact, to think bigger. And so that became a very natural partnership right at our inception. In fact, I think we may have somewhere in the archives, the napkin sketch that Jenny and I did that we brought, to Hemant's back patio as we were, shaping kind of the initial trajectory of Homeward and what kind of business we thought this would be. And, we were sheepishly sketching out, the path to being a $1 billion business. And, Hemant added the zero. He said, this is easily a $10 billion business. And so that's what we're going to go build together. And so I think that initial choice was a really important one for us. General Catalyst has been a supporter, certainly our first backer. They led our seed round, they led our Series A. And then we brought on like-minded investors in our Series B as well. And so those investors, Arch Ventures, Venture Partners being one, and Human Capital Ventures being another, tremendous supporters of our mission, big picture thinkers, long-term thinkers. And so I think those have really been the key to how we've built the financing for this business. And it's what we're looking for as we go forward. Folks, we have a long-term vision. This was never intended to be a quick flip. We're looking to build a durable business that makes a meaningful dent in this really big problem that we look at as, a problem that, frankly, it's at the national scale. This is one that we really want to figure out how to fix because it's going to impact all Americans in the way we look at it.
On the topic of thinking big, let's think big. What's the big picture vision? Maybe let's go out 10 years. We can go out as far as you want or, short as you want, but let's talk about the vision. So what's the vision going to look like? What's the impact going to look like, 5 or 10 years from now?
Yeah. I believe that Homeward has the potential to be a part of the healthcare experience for every rural American. And, whether that's us out front and the Homeward brand being one that you trust, or whether it's us, buried in the inner workings of, care workflows and care delivery, mechanics because of the technology we're building, I think it can be coming from either angle. We're doing both. We're building it all, for the folks we serve today. We're looking for the fastest ways to spread our impact and do that, again, in a responsible way that allows us to reach the most people. The reason I say this, Brett, is in part because, I do believe that the shape of these rural problems is inherently different from the way that these problems show up in urban or suburban environments. And, to collapse it, it's physics. Like, you have people who are spread out. And so there's things that are intrinsic to that fact that mean the solution has to be different. A example I like here is, the kind of experience we're all watching with wired broadband. And the way that wired broadband made its way, to urban America and rapidly spread, it grew slowly into suburban America. It has bypassed rural America. So we left rural America behind when it came to wired broadband. But the exciting thing is we've seen a leapfrog phenomenon. And we've seen that smartphone adoption, and specifically 5G adoption in rural communities, is faster than it is in urban and suburban communities. And it's because the need is so much greater. So I look at that as like a really inspirational kind of analogy for Homeward. And it's almost because there's nothing there for us to disrupt, we have an opportunity to really offer something that can be adopted by the ecosystem in a way that's just much easier to distribute than in a crowded and congested marketplace. So that's part of why I believe that really, Homeward can be a part of the fabric of rural healthcare across, all Americans, whether it's Medicare, Medicaid, doesn't matter who pays for insurance. We really want to be there, kind of supporting rural healthcare for everybody.
Final question for you. Let's end with some advice. So for the healthcare technology builders listening in, what's your number one piece of advice for them to succeed?
So, I think one is maybe the obvious one that I've been talking about, which is, how do you get close to the workflows, and specifically, how do you get close to the patient? And, that one maybe is not the controversial one. I think most builders, most technologists recognize that, user experience and getting close to the user is important. I think what people often neglect in healthcare is that there's other users. One of those other users is the provider. Another of those users is the payer. And so because we have this, ecosystem wrap around the patient, you can't afford to neglect anyone, because that's going to be your Achilles heel. So, if you go and say, I'm going to focus on the patient and the provider, you leave out the payer and you may not get paid. And if you focus on the patient and the payer and you leave out the provider, well, you may never get prescribed. And you may never show up in the provider's workflow. So, you may never actually see the reach that you're hoping for. So I think those are the kinds of things that scare a lot of builders off, these other stakeholders that need to be designed for. But I think it's part of what makes these problems sort of worthwhile. They're rich, complicated problems. And by the way, once you solve them, you enjoy a lot of benefits. You have a great defensive moat, right? You've built your way into something difficult that makes it hard to unseat you. The sort of, Jenny's got a great phrase, ankle biters. The folks who kind of, see what you're doing and think they might be able to copy you really fast. It doesn't show up very often in healthcare, the fast followers. And so I think that's some of the reward is that, if you can design for this more complex group of stakeholders, you can really build and kind of solidify your position in the market, and it's durable.
Amazing. That's a great place for us to end. So before we wrap up here, if there's any founders that are listening in and want to follow along with your journey, where should we send them?
Homewardhealth.com is a great place to learn about what we're building. And you can find me on LinkedIn, and feel free to reach out.
Amazing. Thanks so much for taking the time.
It was a pleasure. Thank you for having me, Brett.
This episode of Category Visionaries is brought to you by Frontlines Media, Silicon Valley's leading podcast production studio. If you're a B2B founder looking for help launching and growing your own podcast, visit frontlines.io/podcast. And for the latest episode, search for Category Visionaries on your podcast platform of choice. Thanks for listening, and we'll catch you on the next episode.